Hi, everybody. How you doing? I feel like everybody needs to take a stretch or something. Hey, look, I'm fortunate to give talks at a lot of different conferences, and I always find patient and family caregiver meetings to be the most enjoyable. And I know you're going to learn a little bit about radiotherapy from me today and what we're trying to do at Northwestern, but I have to say I learned so much from all of you today. So thank you for sharing stories. I was at a clinical trials research meeting, giving a lot of talks the last 2 days in Denver, and then I was asked to speak today, and then I found out that Frankie was talking this morning, and I changed my flight and came home last night at midnight. I'm starting to fall asleep right now. No, thank you. That was a phenomenal story. Thank you to everybody who spoke earlier today. Because, look, when we're in clinic and we're seeing you guys and we're getting phone calls and we're running around and trying to take care of so many patients, we lose sight of the personal story. And the personal story is so important for us to remember and remind ourselves and inspire ourselves. So thank you. So, let's see, which one is mine? This one. Also, I love it when I listen to Josh give talks. I sometimes want to just call him Dr. Summer, because he speaks more eloquently than many of us on this topic. So I'm going to speak about radiotherapy advances for chordoma. So I think, Jean-Paul's, if we're going to be an Olympic swimming team, he's our Michael Phelps or a Katie Ledecky. And it's always a pleasure to work with him. And I give him props for trying to explain radiotherapy as a neurosurgeon. But we're going to go through some of that a little bit here. But at the end of the day, I think it boils down to the fact that radiotherapy, just like surgery, is so critical for the survivorship of our chordoma patients. But what's really important is, number one, how much radiotherapy dose we deliver, and number two, how safely we can do it. And how do we do that? Well, we have to sharpen our edge. We have to make our treatment better, and that's what we've been looking to do. So no disclosures. So here's an example of a clavichordoma patient whom I took care of. And so you can see in the center is the remnant of the clivus in the area of the surgical bed. That's our target to treat with radiotherapy. But around it is a number of really what I like to call high-priced real estate structures. So there's the brainstem, there's a temporal lobe, above it is going to be your vision nerves, your optic nerves. There's a lot of really important stuff in this area. And when I think about it, I think about it kind of like trying to land a golf ball on the green. I'm not a golfer, so I'm sorry about this analogy. But you can think about, there's a sand trap, there's a water hazard, and you're trying to get that radiotherapy treatment right in the middle where it needs to be on the green, and maybe even a hole-in-one, without getting into the hazards. And that's essentially what we're trying to accomplish. So let's talk a little bit about radiotherapy. So Frankie this morning talked about how he came in for 8.5 weeks of radiotherapy, proton therapy every day, and laid there in that mask. And what's happening is every day you're coming in for radiotherapy, we're depositing damage on the DNA of the tumor cells. So the next time those tumor cells try to divide, they cannot. And so they die. So now I'm going to use some biologic terms. So we're causing mitotic cell death. Next time the tumor cell is trying to go through mitosis, they end up going through apoptosis. So the challenge of that is a couple things. Number one, it's important to recognize that when tumor cells die after radiotherapy, it is a delayed process. For most chordomas, less than 1% to 2% of tumor cells are actively growing at any point in time. So when we treat with radiotherapy and we create that mitotic cell death for the majority of those tumor cells may not manifest until months down the road, maybe even up to a year. So some of you who are my patients know I like to talk about this phenomenon called pseudoprogression. And that's really important to understand that when you have intact tumor left behind after whatever surgery, and we do radiotherapy to it, there's a phenomenon of pseudoprogression where the tumor will grow. And I don't know how many times I get that phone call because you guys look in your MyChart and you get that report and it says it's progressing or it's recurrent or it's coming back, or you see another specialist and they say, there you go, radiotherapy didn't work. Well, no, it is working. It's just that delayed process. So that's important to understand in terms of how radiotherapy works. The other important aspect to understand is the number of clonogens. So clonogen is a radiobiologic term. It's the idea that you can take a tumor cell expose it to radiotherapy, and see, does it form its own clone of tumor cells? It's how we look at radiotherapy sensitivity. So when people come to me after an excellent surgery and they say, oh, well, my tumor's all out. Why do I need to do radiotherapy? Well, actually, your tumor's not all out. Your tumor that is visible on the MRI is all out, right? It takes 1 billion cells for something to show up on an MRI, and you had a gross total resection, but they're still microscopic cells, and we can't see them, but we know they're there. And the reason we know they're there is because when we follow you without doing radiotherapy, it's going to pop up into 1 billion cells. So our goal then is to treat those millions or hundreds of millions of cells with radiotherapy. We're not getting rid of it, to what Jean-Paul said earlier. It's very true. We're stunting it. We're paralyzing it, trying to prevent it. So if it tries to grow, it dies. Now, it's easier to do that when there are several 100 million cells. It's harder to do that when there are billions and billions of cells. When we're talking about billions and billions of cells, then radiotherapy dose matters. The more dose we can put in, the more DNA damage we can kill, the more likely we are to create what we're looking for, which is mitotic cell death. So those are just some important radiobiology 101 principles as we talk about what we do next. So the role of radiotherapy. So Jean-Paul mentioned this, and it's very nicely. We think about chordomas and mobile spine, sacrococcyx, and clival. So in my mind, when I see a patient for a chordoma, I'm thinking about, hey, what's the likelihood there's microscopic cells left behind, or even more than 1 billion cells left behind? And in general, in my mind, the only time when I feel like that you've really gotten the tumor out, and there may be a reasonable chance that there's very little, if any, microscopic cells left behind, is what Dr. Walensky said, which is an en bloc resection. But when an en bloc resection is not feasible or not performed, and that's important distinction, my bias is that there is a role for radiotherapy. But it's also important to recognize that these chordoma cells, they're smart little characters. They don't stay contained. They like to travel. They like to swim downstream. And so, Frankie mentioned earlier how his throat was irritated and how he didn't listen to me to not, use his vocal exercise. He took it easier. There you go. But the reason that happened is because his tumor cells were sliding down the back of his throat. You could even see it on his MRI. I didn't pull up your MRI, but you could see it. It was starting to happen. And I knew going down, that's what happens. These tumor cells slide down. They swim down the planes of our normal tissues. And this is a good example of what we call these skip metastases. That if you did an en bloc resection, so there's a nice paper where they did an en bloc resection, but then they took tissue in the adjacent gluteal muscles and they looked at it and took it out and they said, hey, we said this was a margin negative resection, but wait a minute, there's some stuff way downstream. It's 1 centimeter or 2 downstream. And that's part of what happens with these chordomas that we have to, as radiation oncologists, be mindful of. So, importance of radiotherapy dose. So we talked about how it's important with radiotherapy to try to escalate radiation dose, and when we do so, we have to be very mindful that there's some of this high-priced real estate in the area. For skull-based, we're talking about brainstem and optics. For spinal, mobile spine, we're talking about spinal cord. For sacrococcygeal, we talk about the rectum, we talk about cauda-equina, nerve roots, etc. And so our desire to use protons, and we'll explain this in a little bit, or particles, is to be able to sharpen the edge and escalate the radiotherapy dose beyond what those tissues can tolerate, but without impacting those tissues. So some of you know, I like to talk about complications from radiotherapy or side effects as a game of playing the percentages. That, if Jean-Paul does a surgery and he has to take S1, then, hey, you guys are going to have some bowel bladder issues, 100%. But when I do radiotherapy and I treat S1, there's a less than 1 to 2% chance that I'm going to injure those nerve roots and cause bowel bladder function issues to a certain dose. But when I start escalating the radiotherapy dose, that risk starts going up exponentially. So you start playing the percentages, the percentage of how much is this dose really going to help me control this tumor for the long term, and how much is this dose really going to cause a risk, a percent chance of causing a side effect. Okay, so basics of radiotherapy. In general, we talk about radiosurgery and fractionated radiotherapy. Very simple. So radiosurgery is a single or 3 or up to 5 high-dose treatments, whereas fractional radiotherapy is 40-plus treatments that, and smaller little doses that overall achieve a cumulatively high dose. So generally for radiosurgery, to be able to give high doses in a couple treatments or in a single treatment, you need a really small, well-defined target. When you start treating larger targets, not only do you increase the risk of causing injury, you increase the risk of causing so much inflammation in that tumor that we start having bad things happen. When you break it up into smaller aliquots, you can treat a much larger volume. So you can treat tumors that have tentacles. They like to have skip mets. They like to go downstream a little bit. So that gives you a little bit more ability to do that. So, you know, there's gamma knife radiosurgery, there's stereotactic body radiotherapy, that is when you're doing radiosurgery, and then there's protons and intensity modulated radiotherapy. So a lot of fun tools and terms that we have. So this is a paper that I often cite when I talk about how do you compare these radiotherapy modalities. And it did a meta-analysis, and what it showed is that proton therapy relative to conventional radiotherapy actually had better results in terms of durable tumor control, and we'll talk a little bit later in terms of survival. So John Paul stole my thunder. He took this slide. I think I need to send him these slides because he does a good job explaining this. But this is what conventional photon radiotherapy is. It's megavoltage X-rays, and it's kind of like a flashlight. It diverges as it approaches the target, it bathes it in radiation dose, and then it goes all the way through. Now, the only thing we can control about this flashlight are the lateral edges. So what we do is we bring in lots of flashlights that go all the way around. In this case, these are 2 flashlights. Or in intensity modulated radiotherapy, all these flashlights that go all the way around. And it's almost like the spokes on a wheel. So each flashlight, we're able to control the lateral edges of the beam so that in summation, we shape the high dose to the target. Protons are different. Protons are kind of like an open-ended triangle in the sense that we can control the lateral edges, but we also control a third dimension. That's where it can stop. And in the last 10 or 15 years, we've developed a newer technology with protons called pencil beam scanning. And the idea is instead of having one big open-ended triangle, we have lots of little spots that we can control their 3 and even sometimes their 4th dimension, which is what kind of dose they drop before they stop. And so we can drop little spots of protons throughout the target. But one of the areas where we've been really focused on at the Northwestern Proton Center is what I'd like to call sharpening the edges, is using another technology or another tool called brass apertures. These are physical things that we put into the machines to try to have a really sharp edge. So we'll come back to this in a little bit. So importance of radiotherapy dose. So this is a good example of having a sharp lateral edge. A patient of mine I treated many years ago where we escalated radiotherapy to the area where there are microscopic, and in this case macroscopic, there's at least 1 billion cells in some of these areas, to trying to escalate dose beyond 70 gray, but having that sharp lateral edge on the brainstem, which is right behind. So a lot of patients are treated with SRS and stereotactic radiosurgery and SBRT, and I think it's a reasonable approach, and I do it in certain cases. But I think one thing that's important to understand is that one of the advantages of protons is we can treat a larger area. Again, we can do it every day, Monday through Friday for 8 weeks, and by doing that, we avoid missing tumor. And so this was a paper that came out from the gamma knife radiosurgery team, and they talked about the control of clival chordomas with gamma knife radiosurgery after upfront surgery, and they're pretty decent results, except when you read the finer details, you found out that they were missing a lot of tumors, that some of their recurrences actually occurred right outside of what they treated. And this is something that, you know, we tend to I tend to see in my practice, being at the Proton Center, is I see these patients who've gotten radiosurgery elsewhere or SBRT elsewhere, and they come and, you know, we see that they have a recurrence right outside what's been treated. So my practice, and I do believe a lot of us who do chordomas and radiation oncology for a living, you know, we tend to focus on our first time is our best time. Let's treat the whole map. Let's treat the whole area. Do it gently every day, Monday through Friday, and get that high dose as much as we can to that really area where there's a lot of clonogens, and control this. And at some point, it may come back in a small area of that large area we treated, and then we use radiosurgery or surgery to just deal with that. We play a little whack-a-mole at that point. And so that's my general practice when thinking about it. And again, it speaks to the issue of skip metastases or these infiltrative tumors. So This is a good example. So we treated this really large area to a modest dose of radiotherapy to try to kill microscopic cells. But the area where there was tumor left behind, we really boosted that to 72, 75 gray to try to get more dose in there. And so the reason this is important is because we do impact survivorship. Our ability to control tumors durably and ensure and limit the likelihood of recurrence, I think, impacts survivorship, and that's why this is so important. So as I mentioned, upfront treatment is the most important treatment, and part of the issue is that when it comes back, at least in my experience, it has the potential to spread, and we want to avoid that. So it does impact our upfront management. So some of the things we've been doing at Northwestern is, number one, intensifying radiotherapy dose to regions that harbor tumor cells. I can only give so much dose. The more dose I can give safely, the longer I can control this dose. So not too long ago, Dr. Summer and I, Josh and I, used to talk about how one area of research would be really exciting is to develop radiation sensitizers for chordomas. Because, if you look at other types of tumors where radiotherapy is so central to durability of control, but we can't escalate beyond what those tissues can tolerate, the sensitizers have helped us do even better. And then the second is to recognize that these are infiltrative tumors. So we got to make sure that we can treat these more broadly and improve our effectiveness of that. So we talked about sharpening the edge. So some cartoons. This is the green is what we would consider our tumor target, and then this is what we call an organ at risk. So in this case, we'll say it's a spinal cord. And what we need to do is we need to treat this and escalate this area of tumor to as high a dose as possible while ensuring that we don't exceed or increase the amount of dose exposure to the spinal cord. So this is what we do with protons. We bring in a beam that comes in this way, and it deposits those spots in those areas. And then in the other beam that comes in the other way, it deposits spots in those areas. But what you can see, though, is that because we can control the spots, we actually can intensify the spots that are here so that we don't have to bring in a beam that comes in this way through that spinal cord. And we can intensify the spots that are here, likewise not bring in a beam that comes in through that spinal cord, but then do a 50-50 match here to try to get that intensification. But the problem is, when we do that, we are trying to shape the lateral dose, and what ends up happening is you get these little cold spots right around the spinal cord. And the reason that happens is because even though the protons are really sharp, they still have a bit of a what we call a penumbra, a dose fall off. And it's a couple millimeters, and it's a relevant couple millimeters. So what we developed is a technique where we use these apertures that we bring in, and then we, right along the edge of the apertures, we use some of our advanced physics computing to be able to actually calculate how these protons bounce off of this metal brass aperture and end up right in the area we wanted them to, but we intensified them even further to make up for the dose. And that allows us to get the sharp edge we're looking for. So a lot of patients who come to the Northwestern Proton Center say, geez, doc, do I have to get treated at nighttime? We treat from, right now we're going 6:30 till 9 p.m. And the reason is because we actually put the apertures in at nighttime. And so some of our patients end up getting treated at nighttime because that's what allows us to use this technique that we've developed. So here's an example of a patient who had, this is before surgery, had a large clavicle chordoma, large skull-based chordoma, was going down to C1, C2, underwent a great surgery, and then this is the area. We know there's still clivus there. We know there's still tumor cells there. We're trying to escalate radiotherapy dose. So here we're bringing in a beam that comes in this way, bringing in a beam that comes in this way, bringing in a beam that comes in this way, and all those puzzle pieces add up to this, the high dose that we need in that area, trying to land that golf ball right in the middle of the green. So sacred coccygeal. So we talk about the importance of en bloc resections, and we talk about skip metastases. So here's an example of a patient who had a large sacred coccygeal chordoma, but one thing you can tell before they underwent, actually it was just a coccygeal chordoma, one thing you can understand before they underwent surgery is this thing was already in the gluteus muscle over here on the right. This is the right side, FY. So it was already in the gluteus muscle. So you can imagine, hey, this thing's finding a way down a plane. It's going down that plane. Very simple, similar to what Frankie's situation, where I could notice his tumor going down the back of his throat. And so the patient underwent an en-bloc resection, excellent surgery, and then a couple years later came back with that. So this is recurrence in the gluteus muscle. So it was already going down that route. It was already going there. And so this is now important for me to understand. Now, when I treat this, I can't just treat this. I got to treat the entire muscle that's going all the way down to its attachment, because this thing has tentacles. And so this is where we use intensity modulated radiotherapy, but we use something in addition to it. We actually use something called image guidance, where we're able to say, okay, we're creating this intensity modulated radiotherapy treatment to treat this area, but we got to make sure we're lining it up perfectly. And some days it's not perfect. Some days, some bowel slips into place or something doesn't line up the way we need to. So we've developed these techniques using a technology called RadExact at our center, where we can do what we call adaptive radiotherapy, where we're monitoring all these structures in that area and seeing if they're falling into place or not in the right spot. And then once we define that, we can say, you know what, let's replan, let's change our treatment plan on the spot to try to make sure we do this as safely as possible. So I got to admit, I've been here at Northwestern for now 12 years. I remember when Jean-Paul first came out here. Has it been 10 years now, Jean-Paul? And we developed this Chordoma Center, and so many of you came to us for your care, and we are eternally grateful for all your trust. But this is our Chordoma Center. It spans from downtown all the way out to the Proton Center, which I don't know what it would be right now, but on a morning it'd be 40 minutes. I don't know, how long was it for you to get out there, Frankie?
An
hour from work. That's right, from Oak Park was a little easier, yeah. But we're so fortunate to have some exciting tools within our Chordoma Center to provide the very best care. So thank you guys. I know I'm blatting cleanup here, but I thank you guys for all your time and attention for everything today.